This conference will now be recorded.
All right, welcome to the virtual Brain Trust. I am super stoked right now. I got one of my really good friends and mentors in radiology, Dr. Cliff, here with us. Cliff, what's up?
Hey, Sean. Good. How are you?
I'm good, buddy.
Sorry, if you don't mind, there's a little guy that just came in here.
What's up, dude? You're getting big.
You're right there. Say hi. Look at that. Look at that little man right there. You gotta wave. Okay. All right. Now you can go. Sorry.
No, that's okay. This is what this is about.
I want you.
You want me? Okay.
That's okay.
All right. What's going on? Okay, Liam, you gotta be quiet, okay?
That's okay. So basically, the way that this started was through this social distancing. I thought it'd be a great opportunity to bring people with like minds, with passions together, to share information and educate during this process to kind of learn. And then not only that, but like discuss some of the differences that might change because of the situation we're in. And with your knowledge and just your expertise, I'm really excited to have you here today.
Yeah.
Hey, well, thanks, man. Came at a good time. I'm at home.
Is that your friend?
He's my friend. Look at him. What a nice man. Yeah, and I don't know if I kind of missed the last few seconds there, but so I do a radiology, and it's been interesting, I think, from my practice, what's changed and what's not changed. We've had some decrease in volume here, so that's why I was like, oh, it's kind of good timing. So I have some free time here, although my hands are full doing other things. But so I think I have a pretty good idea of, or at least I think so, of at least what's going on in chiropractic in general, but more specifically in the realm of radiology. And I think I mentioned this to you earlier somewhere, that I'm going to talk about current issues in radiology within chiropractic.
Yeah.
Can I do that, or?
100%. I'd love that. And I think if you could touch on some of the lung stuff as well, that would be key.
On the what? Oh, lung stuff?
Some of the lung situations that are going on, and some of your opinions on that, especially if people are going to be taking film.
Yeah. Hey, my buddy's trying to do ball exercises. Is that right, buddy? Okay. Yeah, so yeah, let me do that first. So, in case you have patients that are worried they have, coronavirus infection, the first thing isn't, it depends on their symptoms. If they have bad symptoms and, they're coughing, they have a fever, first of all, I wouldn't want to get close to them myself.
Yeah.
A chest x-ray is a quick way, but it's not a good way to tell. I mean, obviously there's other tests that can be done that are probably cheaper and easier and more reliable. Usually in the first few days of being infected, and even being definitely being asymptomatic, but even into the early symptomatic phase, the chest x-rays is actually normal.
Mm-hmm.
And so so one of the reasons we say, don't necessarily do like a screening chest x-ray is because even though it's normal, we don't want people to think that they don't have the disease. They might have it. If you're telling them they're normal, then that could be misleading them. So a CT is better, but even then, a regular chest CT, that is, you don't really need to do that unless their symptoms are severe, and they've had them, for at least a little bit of time, and they have a fever. So it's generally not recommended at the get-go. I don't actually know what the other tests are, but it's not imaging. Liam, quiet. Shh. So there are, in severe cases, I actually just did a course last week on imaging, of COVID-19, and for CT, they say there are some specific findings, but these are all cases that come from the hospital, so it's bad enough that the patients are going to go there. But I think for typical, probably the I would say, I don't know, the usual patient that comes in the chiro office, they're not going to have that severe symptoms. And if they do, maybe you should, refer them to urgent care or to the ER at that point.
Absolutely. And what advice would you give some of the chiropractors right now that may be watching, or other, physicians or anyone who's interested in radiology? What's some of the things that you would try to instill on people right now? What are some of the precautions, or maybe some of the advice that you would want to give in practice if people are still practicing?
Oh, if they're interested in radiology, hold on, my voice dictation was on. It was actually recording and documenting everything we were saying. Well, we're recording this anyway, but now it's in text form.
I love it.
Did you mean if they're just interested in radiology in general, or?
I know, yeah, I think because I think practice is changing right now, especially with social distancing and just some of the protocols that we've taken. Some of our patients are taking different protocols of wanting to come into the office. A lot of DAC bars may not be available, for, reading films right now. And obviously, hopefully you're still working. I know some that are still, but what's some of the advice that you can give docs right now that are out in the community that may be still practicing, that, are making sure their practices are clean, they're cleaning pre and post, and they are still taking films? What are some of the things and advice that you might want to give them currently?
So specific to this virus thing, and if they're gonna take chest x-rays, it'd be a good time. So, my practice is mostly spines and joints. We don't see that many chest x-rays. And I assume most chiros aren't taking that many chest x-rays, but when we do see them, usually the quality isn't as good. So I'd say, if you want to take a chest x-ray, it'd be a good time to review the parameters and how to take them. And, when I used to teach on campus, we said chest x-rays are special, right? It's not really something we do all the time typically, and everything is different about it. I don't know if you remember this going way back, that the FFD is different. So the tube should be further away from the patient, should be 72 inches ideally. And the patient is P to A instead of A to P, because now we're focused on the soft tissues and not on the spine. The KVP and MAS are all different. So typically we use a higher KVP so we can get more grays or less contrast, so we can see the vasculature, and it would be more sensitive to detecting subtle consolidation and fluid and stuff like that in the lungs. And the MAS is typically pretty low too, because we're imaging air and vessels, not really bone. And so I would do that if you're going to take chest x-rays. And of course, you want to take with in full inspiration, so you have the patient breathe in, maybe breathe out all the way, and then breathe in all the way. You hold it, tell them to hold still, and then you zap them.
Right.
Yeah.
And
so
because a lot of people probably haven't read a chest x-ray in a long time. They are used to the spine joint kind of tissues. What would be a good recap on how to look at it? Obviously, like looking, at the different structures, and what are some things that you would recommend to kind of like a recap on how to overlay that or overlook it? What would be some of the advices that you would give?
Sure. So we learned in school, or at least I learned, maybe you did too, that we follow the ABCs for X-ray, but that's really for bones. And there is an ABC actually for chest. I don't know what it is, probably airway. I don't know what it is, but so there's a different set of things to kind of follow if you want like a checklist to do when you're looking at these chest X-rays. But specifically for pneumonias and for this virus, you want to look at the lung fields to see if there's any consolidation. So consolidation is, even when it's there, it could be invisible on the chest X-ray. So in mild cases, you might be able to see it on the chest X-ray if the technique is good. And so you have to look for subtle areas of increased density on the chest X-ray. So basically, white patches.
Mhm.
And they are typically bilateral in cases of this viral disease, but they could be unilateral, and they're typically in the middle to lower lung fields. So middle, around mid T-spine or lower T-spine, but mid and lower lung fields. And they could have a bit of a pleural effusion. So you're looking, in the corners of the chest radiograph, the costophrenic angles, particularly on the lateral view. So again, another reminder is to do 2 views. You do a P to A view and a lateral view of the chest. And another technique thing that's different from a T-spine is you want to get your arms out of the way. So you have the patient raise their arms up. Hopefully they can, and we're not really concerned too much about the alignment of the T-spine. I know it screws it up when you lift your arms up, but now we're really looking at the chest to get. So we have to get the arms out of the way. And so so PA and lateral view, look for effusion, look for subtle consolidation, which again are like subtle haziness in the lungs. And of course, we can help with that if they want us to do like a second look on the chest X-ray. I would recommend it, especially if they're not reading chest X-rays every day. And then, to be 100% honest, we read them every day, but it's like less than 10% of our caseload is chest X-rays.
Yeah. And I think this is a really good conversation for collaboration right now. You know what I mean?
Yeah.
And this is an opportunity where we as a chiropractic profession can really work with the medical profession right now in a very unique way than ever before, because even we might be seeing patients that a lot of people aren't due to the social distancing, and we need to be up to date on what those symptoms are and how the patients reacting or how they're maybe resolving their situation. And having that, humbleness to be like, I'm going to refer you out to urgent care, or I'm going to refer you out to the emergency room right now for a chest X-ray, and taking the ego out of it. I think, right now we've got to think about the world, and we've got to say, hey, who's the best at looking at this right now? And, the radiologists that may be at the hospital, that's their job. They're in the pathology. They're sending out, they've got people right now that I know in radiology that they're set for this specific, situation in pathology where all the films are being sent to them and they're looking over and they're giving their report and going back.
Yeah.
What are your thoughts on that?
Oh yeah. Earlier when I was talking about how to take the chest X-ray, if you don't feel comfortable taking the chest X-ray, the best way to get a chest X-ray is to go to a dedicated imaging facility that does them all the time. Do you really want to send them to the hospital? Probably not. But if you know of a good imaging center that does chest X-rays, these are medical facilities that have typically much better X-ray machines than we have in our chiropractic offices. And not only that, they're doing chest X-rays all the time, and they have dedicated medical radiologists that read these chest X-rays all the time as well. So that would probably be best, assuming you're okay and the patient is okay with going to an imaging facility.
What recommendations would you recommend on how to start building that network right now? If you work with a lot of different radiologists, what are some advice you can give chiropractors and other therapists in the local community on how to reach out or make that branch happen?
I'm a strong believer that it all comes down to relationships.
Yeah.
And a lot of that is just communication in various forms. So if you have a connection with a particular imaging facility or radiologist or rad tech, just reach out to them, maybe just ask for their advice for something, and you never know what these things will turn into. Invite them to your office, take them to lunch. That's what I do, and I think these things take time. No one is really gonna say, hey, I'll be your best friend, sure.
Yeah.
But yes, it's all relationships, and at least making yourself available if they want to come in or have questions for you. And it might probably be good for our profession too, educating others on just what chiropractors can do, not just your office, but other chiropractors.
Yeah.
So Yeah, giving them food always helps, I think, bring them
Yeah,
some
except for right
lunch.
now. I mean,
Everyone likes that. Except right now, yeah, now might not be the best time, and
yeah.
you kind of have to gauge how busy people are and if the timing works out. But generally speaking, that's probably how I would do it.
Well, I think one thing that, I always, when I'm coaching other docs, I'm like, make sure that, like, if I was in practice right now and I was still seeing patients, I would call every single imaging area in my area and just say, hey, I just want to introduce myself. I'm Dr. Drake. This is my practice.
Hmm.
I am still seeing patients. Are you taking patients? I think that's a big thing. Call these offices, find out who's open and if they're still open.
Yeah.
And then from there, say if the head radiologist has time at any time during the next couple of days, could they give me a call? I'd love to talk to him, because here's the thing is that, asking for advice and getting that sometimes showcases the opportunity for vulnerability and breaking down the wall, right? And in
Oh
this
yeah.
time, there's a lot of people sitting around and they may not have a lot to do. So you can create that relationship very organically at the moment.
Yeah. No, I agree. Someone's got to initiate it, right? Either by asking or by giving, or
Yeah,
both, right? And so, yeah, that's highly agree. Hey, calm down there, buddy. Sorry. Hey,
that's okay.
look at this guy. This
Oh,
guy.
wow, we got a
Look at
pug.
look at all these people. All right, buddy. Is that good? Is that what you wanted? Some camera time? Okay, okay. Cool.
That's great.
All
Um,
right, sorry about that.
No, it's good. I mean, this is really what it's about. Like, getting to see you with your son and your dog, and like knowing, being home, like that's what's going on right now. And people are having to be able to juggle these new ideas and opportunities.
Yeah.
Um, from your perspective in the radiology world up until this point, what are some of the, like, what are three top things that you would like want to hint or teach to chiros in the field, like for their practice? Like, what are three things that you think that we need to focus on coming out of this?
Oh,
Or maybe it's one thing, but what's a few things, or one or few things that you really think coming out of this that you see is something that we've got to focus on as a profession?
well, I think I don't know. I haven't really given much thought to it, but it kind of dovetails into what you're saying earlier. This is a great way, I think, for our profession to collaborate with the medical people, right? Show them how we're a valuable part of the healthcare team. How can we triage these patients and if anything, just reduce the load on them, right? Reduce the load on the ERs and the other medical facilities. We can see these patients, evaluate them. Oh, you don't have coronavirus, you just have the common cold. There's no need for you to go to the ER.
Yeah.
If anything, just reduce the load on them, and we can take care of these patients, and then of course get them better. Another thing, I guess in regards to radiology, is that, and I know this happens in certain segments of our wonderful profession, but and not just today, but all the time, is a lot of people I think hesitate when they order X-rays because of the radiation dose.
Mhm.
And I learned in school and in residency and fellowship training that all radiation is bad. And I think radiation is bad, generally speaking, but now there's all this data showing that it might not be so bad as what we were taught.
Yeah.
And I think that low levels amount of radiation, whatever that is, I think it's probably with X-rays, maybe CT scans and other types of imaging, but definitely with X-rays, that amount of radiation is actually not that bad. And I don't necessarily ascribe to this belief, but some people even believe it's healthy for you. So
Yeah.
I don't know if I'd go that far, but I definitely think it is not as harmful as we were taught. And so, if there's any inkling that that there could be something on the X-ray that could help the patient, help you treat the patient, get better, just take the X-ray, order the X-ray. It's I've never known anyone to have been acutely harmed by taking too many X-rays. I mean, have you?
No, I mean, here's the thing too, is like I'm on the road about 40 plus weeks a year, right? And I'm in an airplane, like, and I thought, and if you look at radiation levels, I mean, pilots have some of the highest in the world, right? They have the least amount of cancer, a majority of them, unless you're a fighter pilot and actually there's a higher level of like cancer and other issues that we can talk about another time. But I think that's a really good point. And I think that one of the things that I'm hoping we have that comes out of this is more compassion and empathy and the ability to say, you know what, like, this isn't about me as the chiropractor. This is about you as the patient. And I may have an idea or a philosophy that, I stick by, but this is really about you. And if I need that x-ray, I need to order it, because if that's going to give me more information to give you better care, or if maybe I got to send you in for a CT or an MRI or maybe a diagnostic ultrasound, but the more information that we have, the better off that we can give that care plan. And not only that, but maybe there's not a mind or a red flag that we miss. And then all of a sudden, that patient's a year or 6 months or, a couple of years down the road, and we could have actually advanced them.
Yeah.
So I really like that.
Yeah, I agree. I mean, and this varies from region to region, but there's it's generally, where you and I are, it's so easy to get an X-ray. It's so easy to get, a little bit harder to get other imaging, but man, X-rays, man, you can get it like next door, and by walking in. A lot of these places don't even take appointments, so there's not that great of an excuse to not do an X-ray, I believe, these days. I know there's different schools of thought, but and it's just I don't want to say imaging is everything. It's just one little slice of our. Oh, don't push that, Liam. It's just one slice of our pie, and when in terms of the full whole body evaluation of the patient, right? So a lot of times, like I get questions like, hey, how come the X-ray didn't show this particular finding? I'm like, well, it's not on there. He's right here. Sorry, my son's in here.
This is good.
So yeah, so the X-ray, we have to realize that the X-ray does not show everything, and we do miss things all the time, but legitimately so. The patient has a disease, like I mentioned, early, any kind of pneumonia, we're not going to see it on chest X-ray.
100%.
And then I don't know if you remember this, but this is how I learned it in chiro school and residency. How much bone loss do we need in the patient in order for it to show up on X-ray? So I learned 30 to 50%. Remember that? I'm like, oh man, that kind of sucks, right? You need to lose like half of your bone, and then only then can you see it on the X-ray. But you know what? It's worse than that. It's apparently that original study was analyzing all the different bones in the body, and so 30 to 50% was the average.
And it's higher than that.
So for spines, it's like 70 to 80%. So
wow.
So we miss. Thankfully we don't see or have patients with tumors, but if we do, a lot of them are missed on X-ray. So we just have to keep that in the back of our mind, and not just with the X-ray, but all tests have sensitivity, specificity, validity ratings, and so we have to keep those in mind. And X-ray does miss a lot of things, but it's cheap and pretty quick and easy to get. So we should not shy away from ordering them, but we have to be smart about it, like using any tool.
And how do you feel, like, one thing that I see a lot is under exposed or overexposed films, right? And I think that is a tragedy, in my opinion, a lot of times. So because I know you see it a lot too, right? And so how can we help our profession and other chiropractors take better films, number one, but more importantly, like, what are some opportunities or options for learning that and then getting better at assessing those X-rays? Obviously, like, sometimes when we graduate, we're like, all right, we're done. We don't need to study anymore. But I know you have what I love that you do every year is your ski trip. You know what I mean? You do your radiology and ski trip. And like, It's one thing
Yeah.
I've not been able to get to yet, but I'm going next year with you for sure. But
All
what I
right.
love about your education is that you make it fun and you make it interactive. And there's a lot of docs that, when they hear radiology, they shut down. They're like, man, I had Dr. So-and-so and that book's flipping heavy and I don't ever want to open up Yoakum Monroe again because they tormented and bullied me. And it's like, it doesn't have
Yeah.
to be that way, right?
Yeah. Yeah. It's funny, we have, I mentioned this actually, last weekend was my ski seminar. And, I said, there are a lot of, I feel like the more education we have as anyone, but particularly in chiropractic, the more ignorant and more arrogant we become. But not all of us, right? And,
Yeah.
we all know an arrogant DAC bar out there. We all know an arrogant sports chiro out there,
Are you trying to say something?
neurologists. What's that? No name. No name. But it doesn't have to be that way, right? We're all colleagues. We're all here to get people better. We have the same common goal. Let's just work together for the interest of the patient. I don't remember what your question is now.
No, my question is about overexposed and underexposed films.
Oh
Like
yeah,
becoming better at that.
yeah. So it's sometimes very hard in chiropractic. One, because we don't have the best X-ray machines in our offices. So just as a comparison, a typical chiropractic X-ray machine is probably under 50 grand for everything, brand new tube and digital receptor panel. Under 50 grand, probably 40. If you're going to retrofit a current X-ray machine, meaning you have a X-ray machine set up already, you want to retrofit it and then make it digital, you could do it for under 30 grand, 20 grand even. That's typical, at least from what I've seen.
Mhm.
But a good X-ray machine at an imaging facility, even outpatient, but definitely in the hospitals, those are 200 to 300 grand.
Mhm.
So these things are, 7, 8, 9 times the price of our X-ray machines, and they get paid the same amount, but they take much better X-rays. And so
Yeah.
we're limited because, at least just from the equipment side, and so to me that means we have to know our technique even better, than the medical guys. We should be the best at positioning because I think we know our anatomy the best.
Yeah.
And I do see a fair amount of positioning errors, or suboptimal positionings, what I'll call it.
Yeah.
But the technique, in terms of selecting the right factors, it can be hard as well, because there's different theories out there on whether to use a particular KVP or MAS, and how to take the X-rays. And so we typically ascribe to the school of thought that each particular body area should have a constant KVP. And
Yeah.
so you should know what it is for your machine and your setup in your X-ray suite. Typically in the cervical spine, we went by 70 kVp, 70 or 80 in a thoracic spine, and 80 or 90 in the lumbars. And then so you can vary, the thing that you vary is the MAS, and that's the amount of X-rays that comes out. And of course, this only really matters in larger or heavier patients. Skinny patients, we should be able to get a pretty good exposure and decent image quality. But once the patient gets big, it can be really challenging to get a good image.
Well, unfortunately, I mean, that's our society at the moment. We are getting bigger. We're getting, we're unhealthy, and a lot of people that are walking into our practices right now aren't healing as quickly as they used to be.
Yeah.
And, if we look at pathology, I mean, it can be chemical, it can be neurological, it can be a mobility cause. So, that's really where, as a professional, like we've got to think outside the box sometimes. And sometimes we focus so much on the joint that we miss some of the other causes of why they're actually in the practice. And, that's why it's so important that if we really feel like we need to take a film, that we have the correct film taken. So that way, when we give it to you, number one, we're getting the best read. You're not having to try to play with the film to kind of make something happen. But, you know, we really like, if we're entrusting a DAC bar or we're entrusting another radiologist to look at that, to give us their opinion, we've got to give them the best situation as possible as well. Because again, think about this, referral wise, like if I'm constantly referring crappy films over to you, are you ever going to send me a patient? Like, you know what I mean? Like that's really what it comes down
Yeah.
to.
Yeah, not for an X-ray. I mean,
No, no, but you know what I mean? Like, so that's a really good point. So when it comes to positioning, like what are some of the positions that you see certain docs miss on a regular basis? What are some of the setups that, you know, if a doc's watching us right now and they've got a couple of weeks to review to get things back ready for their practice and putting things together, what would be some of the ones that you would say, you know what, focus on this right now while you have the time off, or these are the ones that I consistently see kind of off?
So a common one might be like a lateral cervical spine, and you know, to be honest, I don't know if the patient is just you know, in too much pain, or they can't physically be in the proper position. So you know, a lot of times there's rotation in the head is rotated, so you can, you know, it throws off the upper cervical spine, and it honestly can look like almost like a C1-2 dislocation almost if they're rotated too much. So so that's one thing, just making sure, you know, the patient is at a 90-degree angle to the bucky or the detector plate, and that you know, they're looking straight ahead, and you want them to be in a fairly normal position so you can assess their alignment in the natural position, you know. So just have them look straight ahead, how they would normally position their head. You know, if it's rotated, then okay, then that's how they position their head. But keep in mind, if it is rotated, then that's going to throw off our evaluation of the at C1-2. Another one is maybe in the lumbar spine. Well, I don't see this that often, but I guess fairly regularly, is I guess I think it's a Pettibon maybe. I'm not sure of the technique, but sometimes the lumbar spines are done seated, which is fine, but we don't know it's done seated because we can't tell where their legs are. But if I know that this particular doc is Pettibon or whatever, then okay, I know it's seated, and then that's why they don't have a lordosis. And so it's helpful for us to know how you position the patient, whether on purpose,
that's a key thing for
right,
sure,
for your particular technique. Another one is maybe, you know, we see an ADP T-spine. So it's just done, you know, for looking at the spine, and, you know, the heart looks big or something. And like, well, it's, you know, we can't really say, it's probably not big, but it could be. But we really, you know, if you want to assess the heart size, you know, you should do a chest X-ray. So P to A with all those other factors I mentioned earlier. I don't know if it's really, you know, it depends why they wanted to look at the heart size. Is it just based on the ADP T-spine view, or is it because they have symptoms or some kind of history that may lead you to take a chest X-ray anyway? So I'm not saying that they don't always need a chest X-ray, but you know, if it's just based off the ADP T-spine, you know, most of the time it's probably normal, and it's just because the heart is magnified because now it's further away from the film.
Cool. Now, obviously, you know, I work with a ton of athletes. It's like my passion. I love sports, right? So with our sports chiropractors, you know, what are some, especially extremity wise, what are some things that, you know, they should be thinking about, especially in trauma or performance? What are things that you see on a regular basis that are maybe missed, or things that you would say hyper focus on when it comes to that part of the body?
Oh, you know, there's so you know, earlier I talked about missing things on X-ray. It's not just for spines, but it's in all of plain film X-ray. So it definitely rings true in the sports crowd, you know, because it's a lot of it is soft tissue injuries. So you know, the shoulder, there's so many things in the shoulder, right? There's muscles, tendons, ligaments, labrum, cartilage. and we can't see any of those things on the X-ray. So a lot of it is just ordering the right test as per your clinical exam. And so that in the shoulder, that could be MRI of the shoulder, maybe with contrast if you really want to see the labrum well. It's kind of debatable whether you really need the contrast or not. It's better, as you know, to have it with contrast, but sometimes that can delay the exam, and sometimes well, it's more invasive for one thing.
Yep.
It's more expensive as well. But a lot of times, I think diagnostic ultrasound doesn't get enough in the spotlight as it should. And I think I know why. It's kind of a hard exam to look at. I don't even look at them myself personally. We have my associates, do the ultrasounds. I love it just because I know it's an easy exam. It's relatively accessible, and it's very good. It's comfortable for the patient. There's no radiation, even minimal, as an X-ray or CT would be.
And the technology becomes cheaper, and that's going to be such an easy thing for chiros to have in the practice.
Right, and then for sports guys, you could do it on the sidelines even, pretty easily. Not as good of a quality image as you would at a big ultrasound unit, but yeah, you could. I even saw ones that are like kind of hooked up to an iPhone or something. I'm like,
yeah.
That's amazing.
Like Stephen Capobianco from Rock Tape, Dr. Capo, he's really brought that into the Rock Tape education. And they're showing the difference between soft tissue and like looking at this, and then if we do a technique or we do it in some type of intervention, showing the pre and post gliding and tissues, and I think it's a really unique thing.
Yeah, so it's part of it is just knowing what other imaging modalities we have. Everyone knows about X-ray, but we have diagnostic ultrasound, we got CT scans, we have MRI. There's another one. I don't know if you've heard of this. We have a lot of upper cervical docs in our client list, and a lot of them use cone beam computed tomography, abbreviated as CBCT. So a lot of dentists have it, but we have several upper cervical docs that have it in their office, and I think it's an amazing technology that is now somewhat affordable by some chiros, and so I recommend patients getting these CBCTs if we see any abnormalities on the X-ray. It's better than getting a full CT. Probably easier to get than a full MRI. Generally, it's cheaper, and so that's just another alternative for us to use.
And financially, like, what does that cost the patient?
I think it varies, but if they go to a dental office and if they can do the exam, or if they go to a chiro office, I think it's a couple $100 cash wise. I don't know what they would bill insurance or whatever, but yeah, I think it's a couple $100 to get the exam done.
Cool. And obviously, like, we may have 2 weeks, we may have 6 months, we may have 12 months of quarantine, right? Like, that's just the reality of where we're at right now. Are you open to doing more of these with me and actually picking topics and going through some of this stuff as we go into this new world of quarantine for the next couple of weeks?
Yeah, sure. Whatever you want, Sean.
And if docs are watching, because I really want people to learn right now. I want people to grow. Like, take rest. I think that's important. But while you're resting, like, let's become better practitioners. Let's become better chiropractors. Let's become better doctors. What are some resources that they can go maybe sign up for? Like, where can they go learn right now, especially when it comes to radiology in the practice? Like, what can they do right now at home to learn more?
Oh, there's so many resources online. I usually just Google stuff. Like, if there's something that I don't, I'm not familiar with or something, I just Google, whatever, normal chest X-ray or imaging findings of COVID-19. One of the sites that always pops up, I think everyone is familiar with, is Radiopedia. And so go there, you look at a bunch of different examples. earlier we're talking about, how are these docs that take their own x-rays, how can they refine their x-ray technique? One way is just looking at what other people's x-rays look like, ones that are better, I guess, posted online, like, oh, do my x-rays look like that? No, so the first problem is, or the first issue is recognizing that maybe your own x-rays could use a little tweaking. And, so if anything, you get a little bit better technique, but also hopefully also better at looking and interpreting the x-rays as well.
Very cool. And then obviously, if you're a chiro and you're watching, you're listening, chiropractic radiology case discussion is a phenomenal group to be involved with. What are some of the other groups that obviously you post a lot, you help out a lot of different docs, and I'm super grateful to see it especially when you're helping. What are some other areas that or groups or communities that they can join right now in this time to have that community of like wanting to learn, wanting to be better?
Oh, I don't know how many groups I'm part of. So these are Facebook groups, by the way.
Yeah.
So the one you mentioned was what is it? I think it's called
chiropractic radiology case discussion.
Yeah. So that's a great one. There's like thousands of chiros on there. And I will caution that you're going to get a lot of different opinions from a lot of different chiropractors. Yep. Some are right, some are wrong. So I always say, I'm a little biased, but I always think that the best opinion you're going to get regarding x-rays is from a radiologist, and well, not any radiologist, but again, some bias here, but I think DACBARs are probably best at answering anything regarding spine x-rays.
Yeah.
So that's one group. There's another one that's radiology focused, but more for the evidence-based crowd, and it's called Diagnostic Imaging for Evidence-Based Chiropractors or something like that. There's technique-specific ones, and so I'm a member of a few of those, I think, but particularly the CBP crowd, Chiropractic Biophysics, and good group of docs, and we share about x-rays in there as well. What's another one? If you're into doing PI, personal injury work, there's a couple groups out there. One's called World Class Personal Injury or World Class PI Doctors, something like that. Sorry, I don't know the exact name.
No, it's good.
Another one is called PI Elite Community, something like that. Yeah, there's definitely a few of them out there. Chiropractic Community, we don't really see x-rays on there, but
still.
But yeah, a lot of them out there, and again, it's just I like being a part of these focused communities that where we have a common goal. We're all chiropractors, or we're all chiropractors in this specific niche within chiropractic, PI or radiology or whatever, sports. I'm in the sports. I don't know what it's called, sports discussion group or something.
Sports discussion, yeah. Yeah,
so I'd encourage docs to join, especially if they're not working or they have some downtime. What a great way to use technology, right? What could we do? Imagine if this happened 30, 40 years ago, we wouldn't be able to do this. So at least we have this avenue where we can share and learn, become better chiropractors or therapists, whoever's out there, and not have to be exposed to anything.
Exactly, right? Well, cool, Cliff. I definitely appreciate your time, brother, as always. I think it's, I respect you as one of our top DACBARs in our profession, and just the amount that you give is humbling. So even taking the hour away from your family today to get on here for the docs and people that are, wanting to listen or learn, it means a lot. And I think the next one, if we could, maybe next week or later on this week, is do something on possibly sport injuries. I think that would be a really cool topic, and it's something that I think a lot of people would want to hear about, and just say, okay, these are some of the most common. Here's what you might see in your practice, and here's some protocols and techniques to use.
Sure, yeah. Well, next week probably would be better.
I like it. Awesome.
All right. Thanks, man. Buddy. Thanks for having me. Thanks for doing this, by the way.
You're welcome, man. All right.